lines in the second hour for questions to the fertility specialists that we have in studio. So want you to stay tuned and have your questions ready. Na bila kusahau, tapokea mziki wetu toka DJ Machachari, mleta habari DJ OmoshFaya, na tutadunda kule viwanjani na Micah jezi yake nambari 7 mgongoni akituletea habari za michezo. So moja kwa moja toka Kilimanjaro Studios, ni mimi mtangazaji na mwanahabari wako mpendwa Ali Badawy. Kwetu wananiita mteule na wengine mniite mjukuu wa Masai, because I'm Kenyan by blood, American by design, Masai by choice. Sichagui, sikagui na sibagui. Karibuni tena.
Now, let's talk politics.
Now this hour, we're not going to be talking politics, but we have OBGYN and fertility specialist Dr. Kireki Omanwa. He will be demystifying issues on reproductive health. He will also be talking to us on if men are equally culpable in couples that are facing difficulty with conceiving a baby. So stay tuned for that. I'm your News and Politics anchor, Ali Badawy. It's Friday the 28th of October, and we are coming to you live from Kilimanjaro Studios outside Washington, D.C. So please remember to subscribe to our OneMic Show YouTube channel and follow us on Instagram at OneMic Show. On panel with me tonight is Mr. OneMic. We have our resident DJ OmoshFaya. Ruth is also in studio tonight, and Micah is out. Our super producer is none other than Mubelwa Bandio. And tonight we are just gonna go ahead and get started right away, because my oh my, this is a topic that we never thought we'd ever cover, but it's a very important topic, and we will see how this will go. But now we know we've all had mamas and stories about the aunt, maybe the neighbor, or even an in-law who got married but still does not have children. Now, childbearing is considered a fundamental part that fulfills a marriage in most African cultures. Now, not having a child by a certain age is sometimes perceived as a curse and goes with the burden of social stigma amongst peers. Now, for a long time, issues associated with infertility and childbearing have mostly been burdened on the woman, and in some extreme cases, we've seen divorces and even the marriage of a second or even a third wife. Now, the key question in tonight's conversation will be focusing on whether the man may be the one to blame in situations where a couple is struggling to get a child. And to guide us in this conversation is OBGYN and renowned fertility specialist, Dr. Kireki Omanwa. Now, Dr. Omanwa consults as a facility expert at Frontline Medical Center at Ngong Road in Nairobi. He is the president of the Kenya Obstetrical and Gynecological Society. Dr. Omanwa is also a senior lecturer at the University of Nairobi's Department of Obstetrics and Gynecology. Daktari, karibu sana to the US and karibu to the OneMic Show.
Thank you. Thank you very much for those kind words.
Okay.
And it's good to be here.
Okay, great. And how are you feeling today?
Mimi niko sambamba kabisa.
Okay, sambamba kabisa.
Yes.
Yeah, tunapenda hivyo. Now, before we get started on the conversation, what exactly are you doing in the US? Did you just come to be on the OneMic Show?
Yes. That's right. I jumped in.
That can also be an option.
Okay.
Actually, I came for a conference.
Mm-hmm.
There is a conference called American Society of Reproductive Medicine,
Okay.
of which I am a member.
Mm-hmm.
And they have an annual conference every year. Last year, it was actually here in Baltimore.
Mm-hmm.
And
last
year, this year, it was in California.
Mm-hmm.
And actually came from California yesterday.
Okay.
Yes.
So you're fresh from California.
I'm fresh from California.
To be on the OneMic Show.
To be on the OneMic Show.
Okay, we are really happy and we really appreciate it, because I don't know how we would have had this conversation by ourselves. And now the core question which we would like you to help us clarify today is whether men should equally share the blame for couples that are struggling to get a child. Now, historically, the woman has suffered the burden of blame, and we seek to find out if that blame has been fair. But now, before we get on that, Daktari, because I know a lot of people are curious and they want to know that, but before we get on that, on who's to blame or who's not to blame, from your own experience as a fertility expert and as an African man, what is it that you feel scares men from confronting this issue?
The issue of fertility is a complicated issue, especially when it comes to men. I'll start with a story.
Okay. We love stories.
Yes. One time a gentleman came to see me.
Mm-hmm.
He was, I think, somewhere from Marsabit or Mandera. I can't exactly remember.
Okay.
But he came with sperm test result.
Mm-hmm.
And the sperm test result actually showed that there were no sperm at all.
Oh, wow.
Zero sperm, what we call azoospermia.
Okay.
So when I took the medical history, because you take the medical history, what is the problem, how long this problem has been going on, and the information he gave me was a bit sad, if I can put it that way. He had got married quite some time before. The guy was, I think, about in the 40s.
Okay.
And from the first wife, they had a daughter. They disagreed and they divorced.
Okay.
He got married to a second wife, stayed with her for 2-3 years, divorced because they couldn't have a baby. Got married the third time, the same story, 3 years, no baby, divorced. The fourth time, again, the same period of time, no baby, divorced. This was actually the fifth wife,
Wow.
as it were.
And this guy is in his 40s.
And this guy was in the 40s,
Okay.
and the lady was, I think, in the 20s. Actually, I think she was about 25, 26.
Okay.
So, of course, when we get such results, what we want to do is want to make sure that the results are okay. So I sent him for another test altogether.
Okay.
I assumed that the other one was faulty. So the one that came, it was also zero sperm. So he was azoospermic. And
when you say zero sperm, let me scale it down a bit. What exactly do you mean by zero sperm?
Tupeleke pole pole, bro.
That other one.
please,
Azoospermic. Yeah.
Azo, what it basically means is that in the ejaculate, there was not one sperm. There was zero completely.
Okay.
So I sent him for some other tests, and they came back that actually he was not producing sperm at all. So, and he was desperate. With the first meeting when I met him, he told me, Daktari, this is, a do or die. Why? Because the family, the in-laws had started now questioning what is happening. They've been married for 2 years. So it was getting to that time when he normally divorces with the women. And they wanted a baby ASAP.
Yeah.
So when we went through the results again, and he asked me a pertinent question. He said, but Daktari, what is the problem? That is number one. I explained to him, what the issue was. And then he asked me something which I could not, a question which I could not answer. Yes, but Daktari, we had one child with my first wife.
Yeah, that's what I was going to ask you.
Whose is that child?
Yikes.
Wow.
And obviously, I didn't know the answer. I said, I don't know. What you need to do, you may need to go back to your first wife and, have this conversation and see where the problem was or where the problem is. Because obviously from the second wife, third wife, fourth wife, and he was on the fifth wife, he was not going to have a baby with.
Can I ask a question on that part? Because this is the consequences of this. Who was initiating these divorces? Did he tell you?
I think it was him.
Okay.
I think it was him. And then he mentioned something else, that every time he divorced, these women went and got married again and they had children.
Okay.
So obviously the problem was in his side.
Yes.
The only thing is that it's very difficult for us men to accept that we have a problem.
Yes.
And once we don't have that, let me call it strength, quote unquote, to actually come and say, look, I have an issue and I need help.
Yeah.
We have a problem with that. So coming back to the introductory question that you asked,
Yes.
is it possible that we men are contributory to this problem? Yes, we are. Actually, in a very, very big way.
Yeah.
Start from the beginning. When you talk about infertility, this is basically a situation whereby a couple, a man and a woman, the other issues we are not going to, it's beyond the scope of this discussion.
Yes, it is.
They are in a relationship. They are having intercourse 2 to 3 times a week. There is no contraception which is being used, and there is no conception. We call that primary infertility. In secondary infertility is that this couple, yes, the same principles apply, 2 to 3 times of intercourse a week. A year has passed, but in the secondary infertility, they have had a child or children, or the lady has had a conception before, but they're trying to have another baby, and it is not happening.
Okay.
Now, when it comes to statistics, it looks a little bit horrible, let me put it that way. Generally, infertility as a problem affects maybe about 8 to 10% in the developed world, where we are.
Like in the US.
DC,
Yeah.
where we are, it's about 8 to 10%. Europe is about the same. When it comes to Africa, the problem is a lot worse, which is paradoxical, because if you look at the number of children that our women have on average in
more.
Kenya, is about 4 or 5 children.
Okay.
It has dropped from where it was in the 70s, 80s,
Mhm.
where there were 8, 9, sometimes 10 children. So the number has dropped, but still, we still have a huge problem. The fertility rate in our country is about 20%. Sometimes it went to up to 30%.
So let's
Wow.
slow down there. Let's
Yes.
slow down there. So you mean so the 20% infertility rate
yes,
is that an African statistic or specifically Kenya?
it's more or less African. There
Okay.
are other places where it goes up to 30%. There is something we call an infertility belt, and the infertility belt starts from down south. That's not really south, but call it south. From around Zambia, there crosses into Tanzania, touches a bit of Rwanda, Uganda, comes into Kenya, goes to the west, all the way to the west.
Okay.
Now,
Infertility.
One in
Infertility.
5 men.
1 in 5. No, let's not go into the men
Couples.
first. We are just talking about
Or about the
infertility
one in
general.
5
In
people.
general.
Yeah, in
Yeah.
general.
Mhm.
About, let's say 20%. These are the conservative estimates.
Okay.
But it can go even up to 30%.
Oh wow.
So huge numbers. So just to have a sort of a feel of the numbers, if we say that the Kenyan population is about 50 million,
Yes.
and we say that half of these are actually men and women who are capable of having a
Bearing
baby.
children,
So
yeah.
that is 25 million.
Yes.
So 10% of 25 million is 2.5 million.
Yeah.
So 20% is 5 million, give or take. So you
Okay.
can say that the whole of Nairobi, for example, plus a few other counties, Kiambu, maybe throw in maybe Kajiado or Machakos, all of those people who are residing there actually have issues with infertility.
Wow.
It's huge numbers. If you go to Tanzania, for example, Tanzania's population is a lot higher than Kenya's. And if we work with the same average estimate of about 20%, we have huge numbers. So it's a big problem.
So it's a big problem.
Is this like a silent problem? People don't talk about it?
People don't talk about infertility.
Because those are big numbers.
Yeah. Now, even just before we even go to the numbers, the World Health Organization has actually designated that infertility is the 5th highest disability.
in the
5th
world.
highest in the world.
Okay.
So when you go to the supermarkets, you find those parking places which are special for disabled. So
Mobility issues,
yeah. So essentially, we should say, you know what? When you go to parking places, these guys who have issues with they should have their own parking places.
Wow. Okay. I want to remind the
This guy
listeners.
jokes. This guy's got jokes.
Yes. I just want to remind the listeners, if you're just joining us, that you're tuned in to the interview hour of the OneMic show. We're in studio with OBGYN and fertility specialist Dr. Kireki Omanwa. Now, Dr. Omanwa is a renowned fertility expert and is also a senior lecturer at the University of Nairobi's Department of Obstetrics and Gynecology. He's with us today to talk about the taboo of infertility generally and also infertility in men. Now, later in the conversation, he will tell us about some lifestyle choices that can put you at risk of infertility. So I want you to stay tuned for that. Then please remember to share our live stream and like our Facebook page. In fact, I've shared the YouTube live stream. I've pinned it on Facebook. So if you know people who are not on Facebook and want to join in on this conversation, please share that YouTube live link with them, because we're also live on YouTube. Then please remember to share our live stream and like our Facebook page. Do not forget that we are also active on Instagram. So please follow, subscribe, and keep spreading the word. But before we continue, Una, I want to bring you in. I want you maybe to talk a little bit about why men don't engage in this conversation. And then first tell us why, or rather tell us the slight change that we have in format today for our social hour, because we know that people have a lot of questions on this topic. And tell us what's going to be happening, which is going to be in the next hour, the call-in situation.
So there's a slight format change because I think this issue needs to be addressed. And I think Ruth posed the question as to if this conversation is hard.
Yeah.
And Dr. said it is not hard. And I think also it's an issue where we as men need also to start thinking of ourselves as a probable cause to infertility in our relationships. Because like he said prior, he talked to a gentleman who had got married and divorced 5 times. And every time these other wives went, wakapata watoto.
Mm-hmm.
So, hapa iko shida. And I think it is a very, and I think we've had this conversation before where we say, you know what, sometimes it is important to have a discussion between your partner. If you guys are seeking to want to get married, do you want kids? In addition to you wanting kids, are you able to have kids? Are your facilities, the equipment, is it up to par? And I think Daktari is going to tell us what up to par means further down. And then in the later portion, we are going to have a call-in section. Please, maswali mulete. Infertility is on deck, and we have the subject matter expert in studio right here live on the OneMic show.
Okay.
Msingoje kusimuliwa.
Yes, msingoje kusimuliwa. Ndo hii hapa ngoma inachezwa saizi. Wewe usingoje kusimuliwa. Wanna welcome Sunaya Yaipan, Washekendi Rangu, Slay, karibuni sana. Wanna hear your questions. Start typing your questions. Please let us know, like what you want to know. In the second hour, of course, the number is going to be 202-683-4570. Press *5 to speak. That's going to be in the second hour where we're going to be taking in live questions. And Mimo Kwenange here is saying, I'm glad we're having this conversation now. And then Washeke says, the burden of fertility or lack of thereof has always been placed on women unfairly.
100%.
And that's what we're here to demystify. And just piggybacking on Washeke's question, or rather even before going to what might be causing infertility, especially in men, because that's never spoken about, I want to bring in Ruth to this conversation. And I know, Ruth, you have some questions on actually women's reproductive health to Dr. Omanwa. And as you address your questions to Dr. Omanwa, I want both of you to have in mind some blind spots that men might have regarding the reproductive health of their partners or their spouses or their girlfriends or whoever they're choosing to have babies with. Ruth.
Perfect. Thank you so much. I'm glad to be in the studio. Glad to meet Dr. Omanwa.
Dr.
Omanwa.
Just call him Doctari.
Yeah.
Doctari.
So I know when I walked into the studio today, I said, maybe I'm coming to the doctor's office, right? Because there are questions that I, as a woman, would ask OBGYN. And as we talk about infertility, and this is a huge topic in bringing in men around to it, because as you said, men don't talk about it. There's a huge denial about it. But also there are things that I know women would want to hear just about their health. And so men can listen to this. They can ask questions about it. But this is just generally just as a woman. So there is 2 things I would like to talk about right now or later on in the show is fibroids, because that's becoming a huge problem. And also it can impede fertility. And the other one is HPV. I think I got my shot when I was in my 20s, but right now is when men are getting their shots, and there is a huge resistance to it. So I want us to demystify that, what that is, and kind of explain to men why they need to get on board about this. So those are my 2 things I wanted to just make sure that we talk about today.
All right, sure. Daktari.
So can I start with the fibroids?
Let's start with fibroids, yes.
Okay. Yeah. Now, fibroids basically is a growth in the womb. And unfortunately, 40 to 60% of women of African origin, it doesn't matter whether you're Kenyan, Tanzanian, African American, whatever it is, wherever you are from, in your reproductive period, from when you start your periods, that's around 13, 14, 15, until you finish the reproductive period in the late 40s, you will have a fibroid or fibroids for that matter.
Wow.
Now, yes. Now, we do not know exactly why women of African descent or women of African origin have this propensity of having these fibroids, but we deal with them. A friend of mine wrote a paper not too long ago. He said, mine are 100. What are yours? and we didn't know exactly what he was talking about.
Yes.
But basically, what he meant in the paper is that he had removed 100 fibroids from a lady.
From one lady.
From one lady.
Wow.
I've removed 74. So I haven't really got near that 100.
No, that's
but
a lot still.
it's a lot.
Yeah.
Those are a lot of fibroids. Now, what happens is that these fibroids, basically in the muscle of the womb, they're what we call smooth muscle. And in order for a woman to operate, feel like a woman, think like a woman, talk like a woman, behave like a woman, we need what is called estrogen. That is the hormone which is produced from your ovaries. They're the ones with is the hormone which regulates the way women behave. Now, unfortunately, this hormone, they are what you call receptors in the smooth muscle, and these fibroids actually grow from that smooth muscle.
Okay.
So it's sort of, again, a paradox. You need this hormone, and this hormone will tend to, cause fibroids. Other tests have been done, research has been done to look at whether there's any other hormone which can actually lead to that. There's what we call progesterone as well. Progesterone is not possible to actually lead to the growth of fibroids. Now, fibroids can be in different places. So if you look at the womb has a cavity, and the cavity has a lining, what you call a lining, which is called the endometrium. This endometrium is what comes out as a period when there is no baby growing there. So you can have a fibroid growing in that cavity, what you call submucosal fibroid. You can have a fibroid growing, if you say this cup, for example, is the womb. So, and this is the cavity. So you can have a fibroid growing in the cavity inside where a baby is supposed to grow.
Inside the womb now.
Yeah. We are talking about the womb all the time.
Is it uterus?
Is the uterus?
Can we use the word uterus?
The uterus, the womb is just the same.
Okay.
Now, in the cavity, this is where the baby grows. And as the baby grows, we say this is the cup. The better thing would have been a balloon. So inside that balloon, when you blow in air, it grows. So when the baby is growing inside there, the balloon, the womb grows. So uterus grows with the baby. So you can have a fibroid growing inside there. You can have a fibroid hanging outside the womb or the uterus. You can have a fibroid growing outside, now on top of the womb, for example. And you can also have this fibroid growing in the muscle of the womb. So there are several different places where these fibroids can actually grow.
Okay.
Now, the sizes of the fibroids can also vary. Anywhere from a few millimeters, 5 millimeters, 10 millimeters, which is basically nothing, unless it is growing in the cavity where the baby is supposed to grow, then it becomes a problem. You have very heavy periods, you have clots, you may have issues with getting pregnant and so on. And they can sometimes grow to 10, 15, 20 centimeters as well. Now, with the fibroids there are a lot of other issues which accompany that. As I said, most of the time, if it touches the lining, the endometrium, the periods are usually very heavy. Ladies tell us, Daktari, I use 10 pads a day. And I use the maxi, the big ones. And sometimes, even with the maxi, I also have to use a towel.
I want us to pause there.
It leaks.
I want us to pause there. After I use 10 panties a day.
Pads.
Pads. Okay.
Not panties.
Heavy ones and everything. And this is where we want to talk about the blind spots.
Yes.
Because, as a man, who has, your spouse or your girlfriend or whoever.
Your sister.
Or whoever you're with.
Or even your daughter.
Or even your daughter.
Yes.
Yeah. Like, what exactly is it that we need to understand, when a woman, for example, is going through that, because when they tell you, this is what I'm going through, most of the time, we are blank.
Don't get it.
Yeah, we are blank. We're like, you're in pain, there's no context that we have.
Give her medicine and run.
Yeah, so
not even medicine.
Yeah.
Even just going to buy pads for your partner is important.
Correct.
I buy pads for my daughter.
Do you hide?
Yes.
Do you hide when you go to
No,
the
I
store?
don't. Why should I hide?
No, because kuna saa zingine unajua unafaa kujificha ndio usionekana umebeba stay free.
You know, this is something which is natural.
Yes.
It is something which is normal.
Yes.
And actually that blind spot that you're talking about, if she is bleeding that heavily, anakuambia Ali, hebu ende uninunulie pads.
Yes.
Don't
ask a question.
No. Hiyo sio kazi yangu. How do I go and buy pads, you know? These are things which are supposed to be normal, which are supposed to be okay.
Okay.
So those very heavy periods, when they start those heavy periods, the next thing that we want to ask is, are there any clots? Because usually very heavy periods are accompanied by clots.
Okay.
Even by that alone, by 50% of the time, I know there is a problem. I know there is something which is touching on the lining. That is why this lady is having such heavy periods.
Okay.
But sometimes it does happen that the fibroids are huge and the lady is actually asymptomatic at all. She does not even know that she has fibroids.
Okay.
The periods are regular, no problems at all.
Okay.
Now, the other thing that we ask about when we think that there are fibroids is whether there are any pressure symptoms. Because sometimes, if the fibroid is in front, what you call the anterior portion of the uterus, it will actually touch on the bladder. So the lady feels that she needs to go to the loo. When she goes for a short call, she has finished, but after a few minutes, she still wants to go back.
Okay.
And when she goes there, nothing really comes out. The same thing when she wants to go for a long call. Sometimes, if it is what you call a pedunculated fibroid, which is sticking out onto what you call the outer opening of the womb, of the uterus, it can actually mimic cervical cancer. So it will look like it, the structure looks like it, even the smell sometimes, like rotten meat, but it is really actually not cervical cancer.
And there's some questions here that are coming as you're speaking. There's actually one particular one, as you've mentioned, cancer. It's coming from our Diaspora Youth Caucus.
Yes.
And they're saying this is a serious problem. I was just wondering if HPV-18 is cancerous in women and is equivalent to male infertility because men live in denial. Let's start with that.
HPV will come back to it. That's our topic by itself.
Okay.
So let's first do the fibroids, then go to HPV.
Okay.
Yeah.
Yes.
So we'll get back to your question, Diaspora Youth Caucus.
So heavy periods, clots, pressure symptoms. Sometimes we ask, or we do ask, whether there are any issues during intercourse, because again, where this fibroid is located and how big this fibroid is can actually bring discomfort to the patient when she's having intercourse. How long have you had this problem? What about in your family? Your sisters, maybe your mother, did she have these fibroids and so on? So once we've had that history, then the next thing we want to do is basically we want to do a vaginal examination. And that vaginal examination, remember, this is a very intimate and very
Exam.
Yeah.
Yeah.
So we want to do it in a place, it's
Very
intrusive.
intrusive.
We want to do it in a dignified manner where we respect the lady, and of course we want to have somebody there such that, of course, men, not only men, there have been some cases whereby health officers, medical staff have actually molested women. So we want to have a chaperone there with you when you're doing this when you're doing this exam. We want to tell the patient exactly what we are doing right from the word go all the way. And something else which we need to also to ask before we even go to the examination is, when was the last pap smear done, which is also something which is very, very important. Pap smear in Kenya, about 4 or 5% women have actually had a pap smear done.
Talk about pap smear, because remember we're talking about blind spots for men.
There we go.
Yeah.
And that actually will be connected to the HPV, that we are talking about.
Okay.
So when she comes for this test, these are some of the things which we want to cover, because sometimes she may not have that pap smear done at all. So once she has presented herself to you, this is something which you want to do. So we do that we take that pap smear. Once we've done that, is then we actually examine, with our fingers and with our hands. Somebody said that actually for a gynecologist, the fingers are the eyes that actually see. And there's actually a lot of information that I can actually deduce by just, examining using my fingers. I will know where this fibroid is, what the size is approximately, whether there are any other changes in the uterus, if there are any other changes in the ovaries, and so on.
Yeah.
Once I've done that, now I want to confirm what I have examined physically. I'll send her for a scan. And this usually should be a transvaginal scan. I want to emphasize here. Why? Because a transvaginal scan, when you're putting in the probe inside the vagina, the waves actually are very close to the uterus. And the information they get from there, that is when it is changed into a picture which I can see, and the picture is big. And then I can actually see what is happening, as opposed to a transabdominal ultrasound,
Okay.
the one which is done through the abdomen, where you are told, go and drink at least a few cups of water. And when you feel that your bladder is full, that is when you come for the scan. That one is not as accurate as the transvaginal scan.
Okay, very important. Now, before we continue, Ruth, there's quite a number of questions that are coming here,
Yeah.
and I don't want us to lose them. There was another one by Washeke who was asking why we are seeing girls starting their menses at an early age. We have 7-year-olds having their period, and then let's just park that question. There's Vixtana saying this doctor is very knowledgeable and his explanations are very thorough. And then I think we also have Adhiambo Dak, who says, my mom is listening to the OneMic show. Kireki Omanwa. All right, Ruth, back to you.
Hi mom. Hi mom.
Hi,
Kauna
Mom.
skiza nejaga kanyo
for
kanyo.
listening.
Hi, Mom.
Kanyo kanyo.
Yeah.
Yes.
So, please keep the questions coming. We will address them as we go along. But the reason why I really wanted to start with with fibroids,
Yes.
because it can affect fertility
It
for
does affect
women. It does
infertility.
affect. And so the things you say there, and actually one of the things why I wanted us to address is because right now, depending on where the fibroid is or how many they are, one of the leading treatment plans is an hysterectomy, which is an extreme measure.
Yes.
But then I've had a doctor say...
So let's also talk to men, because when
Yes,
you talk
we
to
will.
hysterectomy,
Yeah, hysterectomy is a removal of the uterus, which
Okay.
is
Yeah.
a nuclear bomb, because that means you really cannot have
That's
children.
like the mother of all
That
the
is-
bombs.
that
I'm
is-
all up.
That's
Okay.
it, you know.
Okay.
Yeah.
But that has become. I've had in lots of circles that doctors are like that is almost like a leading treatment plan.
Yeah.
Which again is extreme. But then when you hear doctor says that it's less risky to remove the fibroid, it's less risky to remove the uterus than to remove the fibroid.
Yeah.
Then that becomes, as a woman, you're like, okay, what do I do at this point?
Now, you see, what I normally do is when a patient comes to me and has a problem and have diagnosed what the problem is, before we even go to what needs to be done or how I need to do it, I put my wife in the shoes of the patient. And I say, if my wife was in your shoes, what would I do for her? And that is what I teach my residents during labor ward rounds and in class as well.
Okay.
It's a different thing when you put your wife there or you put somebody very close to you there.
Yeah.
Because then you have a different perspective and you want the best for this person,
The patient.
isn't it?
Okay, yeah.
So when I put my wife there and I tell them, look, if my wife had fibroids, this is what I would do. Because I want the best for my wife. Now, something very important. You said hysterectomy, that is what they're doing. Yes, it is a possibility. But there are so many other things that we can do before we get there. Again, it depends. Number one, have you had a family? Have you had your children? Have you finished the number of children that you wanted to have? Do you plan to have children in the future? And if you're planning to have children in the future, then the issue of a hysterectomy is actually further down the possible options. It is not the first option.
Okay.
Now, again, it depends on the sizes and so on. But something else which we always must mention is that removing the fibroids, what we call a myomectomy, is actually one of the ways that we can treat this problem.
Okay.
However, when we go to theater, if these fibroids are in such a place whereby it's going to be a technical problem to actually remove them, and you may start bleeding and we may not be able to stop the bleeding, then we have to make a decision whether it is your womb or your life. It is obvious.
Oh la la.
But we make we do this counseling before we go to theater, such that the patient knows that actually we are going in to remove these fibroids.
Yeah.
But if it is not possible to remove all of them, or if during the process of removing them, there is an issue of bleeding and we cannot be able to stop that bleeding, then the decision has to be made to actually remove, to do a hysterectomy. We are not going to do a hysterectomy.
Okay. All right, Ruth. Now, like there's so much to cover here.
Yes.
Yeah,
Ding, 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 blind spot.
Yeah, and I think we're gonna get back to that. There's someone actually here who's asking, what's the doc's name again, and where does he practice? The doc's name is up on the screen.
It's everything, doctor. But we'll go ahead and
we'll remind them again. It's Dr. Kireki Omanwa, and he's a fertility specialist. We're gonna, actually paste, all his details. He practices in Nairobi, Kenya.
As well as on the OneMic show.
Yes, at
Today only.
At a facility in Gong Road, and he's a senior lecturer at the University of Nairobi. So we will post those details for those maybe who want to contact him, for those who need a consultation or anything of that sort. We're gonna post those details
for the guys in the 254. Yeah. If anybody who is listening or on YouTube or whoever is listening, it's 5th Avenue offices, Gong Road, 3rd floor, room number 314.
Okay.
And it's there on Tuesdays and Wednesdays from 2 p.m. to 7 p.m.
Yeah.
And I will repeat those.
Yeah.
And I will post them over there.
Yeah, and also post, like the phone number of the facility, the email, so that people can, so that people too asiende nipatie
inbox yake.
Yeah, only daktari, hakuna mambo ya inbox. You have to do things
doctor's
officially.
building, you just go there, stand in the lobby and scream. there are doctors there.
Yes. Yes. Okay, sawa. Now, Washeke and Diaspora Youth Caucus, we've not forgotten your questions. We're gonna come back to them. But Daktari, at what point in life should someone start worrying about their reproductive health? And are there any tangible symptoms, especially for men, that indicate something may be amiss, Daktari?
I think I'll start talking with the mothers, first of all.
Okay.
So when we have this little boy who has been born, and we are all very happy and proud that now I'm a man, because unfortunately that is what happens. Usually what happens is that when this little boy is in the mother's womb, just before it is born, the testicles actually drop into the scrotum.
Okay.
Now, when he is born, they are supposed to be in the scrotum already.
Okay.
So here is talking to the ladies when they are washing their little young men to actually check in the scrotum, just to feel that a tiny thing, there's something there which feels like a bean.
Yes.
It must be there.
Yeah.
Now, that is where we should start checking.
Okay.
Because what happens is that sometimes you find we are not aware that actually the testicles, maybe one side or even both sides, they did not descend into the scrotum. The gentleman will grow up, will have all the secondary characteristics. You'll have your beard, your muscle, the testosterone is pumping through the system, but the production of sperm will not be there. So you find he gets married and everything is fine. They start trying 2 years, 3 years, sometimes even longer. And obviously everything is okay from the lady's side. The man, he has never been tested. We have an aversion to go and have ourselves tested. So when he comes, you find there is no sperm, azoospermia. So when you talk about azoospermia, there are several reasons why there may not be sperm.
Now, before we go further, when you talk about no sperm, let's be specific here, because for the non-science mind, when they're thinking sperm, they're thinking that fluid that comes out during ejaculation.
Okay.
So is that what sperm is? So that means if that fluid is not there, you have no sperm?
No.
Or what exactly does no sperm mean?
Now, blind spot. Ding, ding, ding. That's a blind spot.
Exactly.
It's a blind spot.
Yeah.
Now, normally what happens is sperm is produced elsewhere. It is stored elsewhere. During intercourse, when a man is having an orgasm, sperm pushes, David says we are wonderfully and beautifully made, and that is one of the things. It takes microseconds for that sperm from where it is ejaculated to pass through the tubes, pass through the prostate gland, where it is mixed with seminal fluid. That is the fluid you're talking about.
Okay.
And then it comes out through the urethra, where the urine comes out through as an ejaculate with sperm.
Okay.
Now, when you're talking about azoospermia, meaning no sperm, it basically means that what comes out as an ejaculate is only the seminal fluid, but there is no sperm.
Now, is there a way of knowing that just by looking at it, or is that something that has to be tested?
Very good. Now we have to test it.
Okay.
That is why now when a couple comes and says, look, we've been trying and this, we've taken down the history. For the gentleman, we tell them it's a very simple procedure. You go to a lab. First of all, you abstain from intercourse 3 to 5 days. You go to a lab, and they'll give you a container, and you give a sample.
You
Two
mean
ways
you
of
mean they
giving
give you a
sample.
porno and you watch and then unatoa zile
In
vitu?
some places they have, some places they don't, but end result is that we want that sample.
Okay.
Now,
Whichever way you
whichever way it
produce
is, there are
it,
two
yeah.
ways. Basically, is masturbation most of the time, and there are special condoms, which I don't know whether they're available here in the US, but in the UK they were available. Not the normal condoms, because the normal condoms actually have a spermicide. So once they have
Wow,
given us that
okay.
sample, it is left to stand for about 15 minutes, what we call liquefaction time. It needs to become watery, because there are so many parameters that we are going to check in that sample. First of all, you are going to take it in a pipette and pull it and see whether, it is longish. Ni kama makamasi.
Okay.
Sawa sawa. We are going to look at the color. What color is it? Because that color will give us insight about what is happening. We are going to check the pH of that sample. We are going to look at how long it becomes liquid, becomes watery. Then we start looking at now the sample itself under a microscope, because with the naked eye you cannot see anything, you just see fluid. And again, this is another amazing thing, that out of sperm which are invisible to the eye, it has all the genetic coding that is going to decide Ruth's son or Ruth's daughter is going to have, this height, once they have, mixed with the egg, these are the characteristics of that baby. It's mind-blowing, out of this world. So we look
You can get that from the sperm test.
well, no, we look at the numbers.
Oh,
We look
okay.
at the character. But
Okay.
now these are things which are in that small head.
Oh, okay.
Everything is there.
Okay.
So we look at first of all, we want to see whether they're sticking to each other, because sperm can stick to each other. They can stick head to head, head to tail, or even tail to tail, or you may have a mixture of these actually on the slide, which you can see. That is already a problem. It's not supposed to be there. We look at the number of sperm in 1 milliliter, what we call the concentration. We looked at the volume. We want the volume to be at least 1.5 milliliters or more.
Okay.
Then we look at the concentration. How many sperms are in 1 milliliter? We want them to be at least 15 million or more.
Oh, wow.
Then we want to look at what is the count. So if you have a volume of, let's say, 3 milliliters, and we have a concentration of, let's say, 20 million per milliliter, so we multiply 3 by 20, we get the count, which is 60 million. And we want it to be at least 40 million or more. Then we look at how this sperm is actually swimming, because in order for it to be able to move from the cervix, where it is placed during ejaculation, and travel all the way through the uterus and through the tube until it meets with the egg at a particular point in the tube. It just doesn't happen just like that. It is a particular point in the tube. It has to have good swimming ability. So there are 3 or 4 different types of motion or motility. There is what we call type A, which swims very fast. If you can...
Kama
equate-
Usain Bolt.
Usain Bolt. The sprinters.
Oh, Omanyala.
Omanyala.
Why are you going out there?
Yeah, stay home. Let's keep it home.
Omanyala.
So kuna Omanyala.
Kuna Omanyala.
Yeah.
And then now there's type B,
Uh-huh.
which swim not as fast as the sprinters, but also they have a direction. So let's call that Kipchoge.
Jogging. Nice. So it's a marathon runner.
It's a marathon.
No,
Okay.
kuna 3,000 meters.
Kuna 3,000. Yeah.
3,000
meters, steeplechase.
Hapa steeplechase. Haya,
okay.
daktari endelea.
Sawa, sawa.
Ezekiel Kemboi.
Huyo. Alafu
And then there
I
are
know
others. There are others which actually just swim in one place and they don't go anywhere.
Okay.
So it's in one place swimming. Ni kama zimelewa.
Okay. Yeah.
hold on.
And then there
I
is the
feel
last
attacked.
one, which are immotile. They don't move anywhere. So what we do, we actually take the first one, there's the sprinters, the omanyalas, and the kimbois.
Yeah.
Hizo ndio tunaziweka pamoja.
Okay.
A plus B. And we want that to be at least 40%.
Okay. Okay.
Sawa.
Okay.
Now, then after that, we go to look at now what we call the morphology or the normal structure of that sperm. It must have a head, which is usually ovoid in shape. It has a neck piece, and then it has a tail.
A tail.
Now, we want that to be only 4% or more. So imagine out of that 60 million, the count,
Yeah.
4%, 10% will be 6 million. So
Yeah.
1% will be 600,000. So 4% will be 2.4 million. So you just want 2.4 million or more.
Okay.
Now, apart from that, we want to see whether there are any white blood cells. White blood cells would actually signify kwamba there is some sort of infection. We want to see whether there is fructose, which is also good for the sperm to swim.
Okay.
We want to see whether there are any red blood cells. That is not a good sign. We
Okay.
want to see whether there are any bacteria or any yeast around there, because that
Okay.
will also mean that there's an infection. Either there's an infection, or the way this ejaculate was collected was collected due to normal intercourse. Because during intercourse in the vagina is very, very rich in all manner of bacteria and whatever, which is also important for that ecosystem in the vagina to survive.
hold on.
Yes.
Repeat again. It's very
Ding,
rich.
ding, ding, blind
Very-
spot, blind
Yes.
spot.
It's very rich.
There are good
No.
bacteria
Blind
and bad
spot
bacteria.
alert.
We're talking
Bacteria.
about good bacteria.
Yeah.
And we want a balance.
Yeah.
We want a balance of
Okay.
that.
Okay.
So now, when we look at these results that we get, is when you can tell a patient, you have an issue with agglutination. Your sperm is sticking to each other. Not a good thing, because getting pregnant, that is actually a reason for you not getting pregnant. We can get around that. You have an issue with the numbers. For example, instead of 15 million per milliliter, you have 2 million. Too little, too few.
Okay.
And when you multiply 2 million by 3 milliliters, it's 6 million. And we want 40 million.
Okay.
So what we call oligospermia.
Okay.
The numbers are there, but they're reduced.
But
Okay.
that sounds like
So-
a Jaluo. At your legal who?
when Daktari is talking, the voice of my biology teacher is coming back, Mrs. Oyomno. All the terminologies that he's using, that voice is coming back, like slowly by slowly, which goes to show you the importance of
Trauma's a high school boss.
of studying. But no, it wasn't trauma. I think
Some
it was
of
a
us
very
were
important
traumatized. I don't know about you.
subject to. It's a very important subject to
know about
study.
you.
Yeah.
Now there's we are gonna come because we are still like at what might be causing the infertility, and we're gonna come to
Yes.
if there's remedies to it. But before we get there, there's a
Yes.
question here that's coming. Mimo Kwenange is asking, Doctor, is it too late for a girlfriend to check their man's balls to make sure the cabin is there? Not meant to be funny. This is a very serious question.
Now for
By
the
cabin.
for
Yeah.
the for the for the
sorry.
girlfriend, it won't be a cabin. It will be something which is the consistency is hard, and we need to have a rough idea about the size as well.
Yeah.
So she may probably not know that consistency and that size. So
Yeah.
how to check it is just basically to confirm that it is there, but whether it is okay is a different story altogether.
So it can be there.
It can be there,
But it's still not
but
okay.
the size is small,
Okay.
or it is soft, the consistency, or it may not be there, it's in the abdomen.
Let me
Okay.
ask a question to that.
Yes.
So as from 13,
Yes.
as women we're told, you start seeing your OBGYN. Not from 13 to 19, 20, not as frequent, but if you do not get your period,
Yes.
you will have to see a doctor for that.
Yeah.
That's why when you said it's a normal thing, I remember when I was growing up, going to buy my pads, I was in high school, at this supermarket, and normally ulikuwa tunaamba ufiche.
Yeah.
And I was like, if I don't have periods,
Yes.
my parents or my future husband will spend so much money trying to figure out what's wrong with me. This is so normal.
Yeah.
So I was proud holding my pads, going to
That-
pay for them.
Yes.
So it's actually a serious thing if you don't get your period.
Yeah.
So you have to see a doctor. But then from your 20s, you're advised to see your OBGYN once a year.
At
you know,
least, yeah.
at least. Do men have that? Because that's my blind spot.
Now, men don't have that, unfortunately,
Okay.
because it is assumed, again, is another blind spot, that men are okay all the time. As for women, because of that cycle, you have something to show, something exterior. There is a pad, you know. Men don't have to. So it is assumed that they are okay. And that is why infertility affects about 35 to 40%. Men actually have the problem with infertility. About 35 to 40%.
Repeat that again.
So wait.
35 to 40%.
So when you say 35 to 40%, do you mean 35 to 40% of men or 35 to 40% of people who are
cases.
having infertility problems?
35 to 40% of the population of men
Uh-huh.
have an issue with infertility.
3 to
Wow.
4.
Wanaume.
That's
We-
a
fungeni show.
yes.
Fungeni show.
Wanaume.
Fungeni show huyu jamaa ende.
Yeah.
Fungeni show huyu jamaa toke.
It's a big number.
That's
Yeah.
how they react.
It's a big number.
Yeah, and I think that is very telling because most people are hearing this for the first time.
Yes.
You know, like people don't know. And of course, like I remember at the beginning of the show, we're talking about, you know, that this problem has historically been blamed on the woman.
Women.
Yes.
But we're seeing here there's a very high likelihood
Yeah.
that the man is the one who might be having the problem. There was a question that Washeke asked, and it kind of
Actually, there are 2 questions we need to get back to before we forget
got
them.
lost.
Yes.
But Uno, you go first, and then we're gonna come back
As
to
you're
these
going,
questions.
as
that
you're,
were
as you're
asked.
going to those questions, let me to support your point.
Yeah.
Today, in preparation for this show, I was talking to a pal of mine, and I was talking about infertility, and I told him, and I think that the doctor mentioned where sometimes when a child is born, and he can correct me, but listening to his presentations,
Yes.
something is supposed to fall in place
Yeah.
in the scrotal sac.
Yeah.
Something is supposed to fall in there so that it can be supported.
Yes.
Now, from there, that is where we get, I guess, the sperm or something.
Yeah.
But sometimes at childbirth,
Mm-hmm.
if you're a boy, or before childbirth, I think when you're born, those things don't fall in.
Yeah.
They don't fall in place
Yeah.
to make sure that now everything is aligning is aligning such that as you grow, you know, you're going to be that Guruma Simba.
Yeah.
He did not know that sometimes those things happen where your testicles don't fall
in place.
fall in place into
Yeah.
the scrotum. He did not know that.
Yeah.
They do not descend. That is the
Oh,
word.
sorry,
Yeah,
they
and
do not
descend.
descend. Oh, my bad.
And
my
I
bad.
think it would be best even in another forum if maybe you could even use diagrams, because you're talking about mothers checking, and I think fathers too should also be involved in this, checking their boys,
100%.
you know, like when they're young, to see if there's a problem so that they can know early. And then I think it's also, I mean, if the numbers, you know, like the numbers that you're giving us, if that's a case, I think certain things, you know, like when men go for their annual checkups,
Yeah.
I think this is something
Yes.
that should be included.
But before, hold on.
Do men go for those annual checkups?
That's
It's
another.
something else.
Hold on.
though.
I think we need another show for
Okay,
that.
daktari.
Yeah, we need another
Nimewaambia
show for
bana
that.
huyu jamaa toke
But
hapa.
daktari-
This is
Daktari
second-
knows too
second
much.
warning, second warning,
but
second warning.
daktari,
warning.
Yeah.
but daktari, okay, if those things have not descended,
Yes.
is it something that you can tell, let's say when you go for your for the, you know, like when the woman goes for the checkup, you know, like when you're going for the before childbirth, you know, like you're looking at, you know, when you do that ultrasound,
Yes.
is it something that you can see then? This thing can only be this can only be confirmed once the baby has been born.
So the baby has been born,
Yes.
and if we actually feel, you can actually feel kwamba, yeah,
Kuna kakitu
hapa na hapa kuna kakitu.
Yeah.
Ama hapa hakuna, and
Yeah.
here it is there.
Yeah.
So it can be, that is why I said right at the beginning, talk to the mothers.
Okay.
And especially when they're washing the the
babies.
But I think also maybe they
Now-
should also be taught because they don't know exactly probably what
That's
to
another
feel for.
thing.
No,
Yeah.
the babies can't know.
No,
but
no,
even
no, I'm
the
saying the
mothers,
mother.
But the
women,
mothers,
The
yes.
mother,
The
yes.
mothers
like-
should. The
But
mothers
also,
should.
you know what
To
I
be
want
taught,
this
like
is
that
what
should be
the-
part of the when you're going for the prenatal.
Yeah.
Like this is what you're supposed
I
to.
want
feel.
to
Go ahead.
add to this
Yes.
because right now we are all doing intentional parenting. So men as are more present as fathers. This is one route that you can definitely be part of your child's
Absolutely.
life.
Absolutely.
Yeah.
So now, coming back to your question, do we know, how do we know? They present now later on with the problem of infertility. Tumejaribu? Na haifanyikani.
Could it have been fixed then?
Sorry, if it
it's
is
detected
discovered earlier
Yeah.
in childhood, yes, it can be fixed.
Okay.
Okay.
Good to know.
So now when they come later on, you do a sperm test. There is no sperm. You're asking, what exactly does azoospermia mean? So I explained, there's sperm. Azoospermia, there's no sperm at all.
Yeah.
So
It's
the
just
next
an
thing-
empty fluid.
It's just fluid, seminal fluid. So the next thing we want to find out, where is the problem? Because there can be two issues. There can be what we call there are blocked tubes, and there can be another issue where the tubes where the sperm pass through, they are okay. Now, if the tubes are blocked, because remember I told you they are produced somewhere, they are stored elsewhere.
Yes.
And they move and they pass through the prostate, they come out with as an ejaculate. If the tubes are blocked, what do we do? Or what do we do? How do we try and find out whether the problem is production or not production? We do a hormone test, that is a blood test, and then we also do that scan that you mentioned.
Okay.
So we do a hormone test. There are about 4 or 5 hormones which we do, and we find that the hormone levels are fine. So if the hormone levels are fine, and we have done a scan, a scrotal ultrasound scan, and everything is fine, the testicles are there, they are good size, the blood flow is okay, there is no fluid around the testicles, the veins are not swollen, etc. So we find here it is okay. So the issue is basically blocked tubes. All right. If we do that test and there is no sperm, we do hormone test. We find that the hormone, 2 or 3 of those hormone levels are elevated, and we do a scan. We find that in the scrotum, yes, the testicles are there, but they are small, what we call hypoplasia, and the blood flow is okay, and there's no any other pathology. So the issue is production.
Okay.
So that is a very easy way of, finding out what the problem is. There is also another third issue where you have a congenital problem, a hereditary problem, whereby there's a problem called mucoviscidosis,
Yeah.
whereby there is mucus in any organ which has a hole, has a lumen. Mucus accumulates there.
Okay.
But fortunately, this is not a problem we have in our part of the world.
Okay.
It is very, very prominent amongst the Jewish people because of intermarriage and passing this genetic
wow.
problem to their
Okay.
children.
Yeah.
Those ones will never have children.
Let me drop a big
Okay.
one. Vas deferens. Go ahead, Kanye.
Yes, and that's what will bring us to our next question. But I know there were questions here that were there. That one about genetics. Because it's something that I want us to talk about. But let's go to the questions that were asked earlier.
Let's address this because I think we moved from, I had said fibroids, HPV, then we go to infertility. But it's okay. So
yes.
it's okay. So we're going to go back a bit,
yeah.
address
Okay.
HPV because we're going to answer a question, and then I'm going to start with the question from Asheke. So
Okay.
Asheke wants to know,
Yes.
let me get to that. Why are we seeing girls starting their menses at a very early age? Normally, it used to be 12, 13, 14. It's dropping to 7. They're still kids.
Yeah.
Suggest that.
Actually, the average in Kenya is about 13, 14 years.
Mm-hmm.
Very rarely do we find one who has started, a little bit earlier.
Mm-hmm.
What we are seeing, and that is the research which has been done in the past, and there is evidence, what is called precocious puberty, whereby you find these very young girls. Sometimes some of them have breasts, they have cycles and so on. It could be an endocrinological problem in that the body is not functioning the way it should. It has started functioning too early, and it's not supposed to be that way. The other thing which has actually been found is because of the food that we eat, and especially in this country, whereby the chicken, for example, they have been pumped with hormones, and those hormones actually get into our system, and this leads to activation of the endocrine system a lot earlier than it should. So we have an issue with that, and it is also getting to our
So
places
this is
as well.
diet.
So
Substantial
the
diet.
GMO that now is a topic in Kenya.
Yes.
Is that part of the diet that is leading to this issue, or maybe that's a
The
whole
GMO,
other
I think the GMO is slightly different.
Okay.
But here is a case whereby, for example, chicken are fed, they are pushed to grow very
Fast.
fast.
Very
Yeah.
fast.
In maybe 45 days, they're already, they're
Mature,
ready to
yeah.
be mature. And normally they cannot grow that fast under normal conditions. So they are fed with hormones, they are given antibiotics and so on and so forth, such that they, is the market. And not only chicken,
Diet.
even the cows as
Even
well.
the cows, yeah.
Yeah, they're given hormones so that they can produce more milk and so on. And some of this milk actually some of these hormones actually do get into the food chain, and we consume them. And these are some of the problems that we are facing now.
Wow. Okay. Let's. My follow-up question would be: so, what do we do to prevent that from happening? Because I think that is that's very scary. But I think we're already in the problem.
A difficult thing to sort out.
Move back to Kenya.
I'm not very sure. I mean, we can move back to Kenya, but even in Kenya, we are also
Yeah, we have the same problem.
broiler.
KFC kondani ya
Monsanto,
nyuma.
deep.
Yeah.
So I think maybe you have to be a bit more careful about the foods that we eat, especially animal protein, because plant protein, we don't give them any. They are not given any
Growth
hormones to
hormones,
grow.
yeah.
Okay.
So that is something else. But then the other thing is that with the plants, there are herbicide and pesticides as well, which you also have to
Monitor,
balance.
yeah.
Yeah.
Oh, okay.
Now, the interesting thing is that I know, because I travel a lot around East Africa.
Yeah.
In the island of Zanzibar,
Yeah.
they allowed Purdue chicken to set shop there.
Yeah.
So some of this nice chicken that you're eating, for those who've been to Zanzibar at Forodhani,
Yes.
that's Purdue chicken. The Tanzania mainland,
Yeah.
walikata.
Very sensible.
Yeah, Tanzania mainland walikata because they operate under two systems.
Yes.
Now, I think Purdue also set shop in Kenya, if I'm not mistaken.
I think so.
Yes. Purdue chicken also set shop in Kenya.
Yeah.
So people in
Is that why
Kenya
Kenchik left us, boss?
are also eating
Because I'm missing
Purdue
them.
chicken.
Oh, sorry.
Which is that chicken that has
Yeah.
those hormones that
Madogodanio.
Daktari is talking
Mashakura.
about. So this problem is in Kenya, Ruth.
Yes. Because of time, you need to move to HPV.
Okay.
I know we kind of have to come back to this, finish this, and we can go to infertility.
Yes.
HPV. The
Yes.
question on HPV
Yes.
was so there are strains of HPV that can cause cancer.
That is true.
And these are part of pap smear.
Yeah.
They screen for that
Yes.
every year because
It depends on the country, and
Yes.
it depends on the guidelines.
yes.
Yeah.
So this person asked, I'm trying to go back there. It's a serious issue. I was wondering if HPV 18,
Yes.
please tell us how many strains there are that can cause cancer, is cancerous in women, and is it equivalent to male infertility because men live in denial? I don't know what they mean by that. Probably you do. But can you please talk about HPV,
Okay.
how it's transmitted,
Yeah.
who are the carriers,
Yeah.
etc., etc.
HPV, human papilloma virus. Again, as the name suggests, is a viral disease, which there are hundreds of strains or hundreds of subgroups of HPV, and some of them we actually have seen. Maybe when we were growing up, you find somebody has something here which is growing. You think, in where I was coming from, where I come from, they used to say, huyu ni yule anachokoza watu. That is why it is growing there. But
Wow.
basically, it's a wart. Okay? So apart from other warts, it also is a cause of genital warts. And these genital warts can grow anywhere around the perineal area. can grow in the vulva,
Inside?
on the cervix, yes, and sometimes they're humongous, and they also look like cabbage. When they come out, it's horrible. Sometimes when you look at them, you can have a nightmare. Now,
That's shocking.
it is shocking, very, very shocking. Now, yes, there are strains. Actually, the gentleman who got a Nobel Prize for Medicine and Physiology was actually somebody from Germany who actually proved that HPV is the cause of cervical cancer.
Oh, wow.
And he actually went through in his research, and he actually came up and said, look, this is actually the connection. And usually from infection until you have the first signs of cervical cancer, the time frame is about 15 to 20 years, which coincides with usually the time when a woman, ladies start having their first intercourse. So if your first intercourse around 15 years, 16 years, and then by the time we have the symptoms, the signs of cervical cancer, you are about in your 30s, late 20s, early 30s.
Okay.
Now,
In this period,
yes,
if it's caught,
yes.
can it be prevented?
Now that is where the vaccine comes in.
Okay.
The vaccine comes in because before that, before there was not this clear, connection between HPV and cervical cancer, basically we were not doing anything about it. You would come, a lady would come, and we see that there are vaginal warts. We would actually, treat them. There's something that we'd use and we treat them. If they are very big, we'd cut them and use liquid nitrogen to remove them. Or sometimes you just cauterize them with energy.
Okay.
Now, the fact that now we do have a vaccine, it is better to prevent than to wait. Oh, nikipata ndio nitaenda kupata vaccine. It's better to go for the vaccine.
Yeah.
Now, there are different types of vaccines. There's a vaccine which covers only 2 of them, 2 subgroups. There's another one which covers 4 of them, what you call a quadrivalent vaccine. And there is a new one which is supposed to cover 9 subgroups, what is called a nanovalent vaccine. In our part of the world, we have the one that covers 2 and the one that covers 4.
Okay.
Talking about the pushback about
Can
the vaccine.
let's talk about the pushback on
And
vaccine.
we're now running out of time. We're really running out of time.
Yes, but we
yes.
do need to address because it's very important as well.
Okay.
Yes.
Now, before we even go there, there's the issue of how is it transmitted.
Yes.
It is a sexually transmitted disease. So you will get somebody who has it, and having intercourse without protection. The man has, without using a condom, actually can transmit it to you. Or he can also pick it from you and transmit it to somebody
someone
else. Okay?
Yeah.
So it's a 2-way or even 3-way, call it 3-way. So the best thing to do, is to zero grace. Call it that way. Have one partner, and that is it.
Okay.
What about the vaccine to men? Because that's a very new thing. Men are pushing back on it.
Yeah.
And then we finish.
Now we need to
And
take
then
a
we
break.
finish.
We actually need to take a
We'll
break.
take a break after this part.
Yeah.
And
then we're gonna come back.
Just
Kunywa
one,
maji,
2
kunywa
minutes,
maji.
2 minutes, and you take a break.
Okay,
Yeah.
now the issue of vaccination actually something which has been propagated for quite some time. And there is, because if we know that the life from infection to cervical cancer is about 15 years, so why don't we vaccinate all young girls such that by the time they get there, they will be protected, which is a good idea because prevention is better than a cure. Now, they went a little bit further and said, why are we vaccinating only young girls? Why not vaccinate also
The
boys.
young boys as well? Which has actually been taken up by some countries. For example, in Australia, some states of Australia took it up very well, and they did that. Some countries in Europe have actually taken it up. Texas had a problem even with vaccinating the young girls themselves. In Kenya, what happened is that we had a pilot study where some counties, one of them I think was Kitui, and 2 or 3 others, whereby they actually got free vaccines to vaccinate girls. But there was a lot of pushback from the parents saying, no, what you're doing is actually you're opening the gates for these young girls later on to be promiscuous and so on and so forth. A small problem that people don't talk about is about those words, the boys actually getting those words in the trachea, the breathing tube. Because for those ones for the men who do oral sex, actually can get those words from an infected lady, and that can be a problem. A small problem as well is about penile cancer. They can also have penile cancer. Also the same sort of mechanism, even though the percentages are quite small.
Okay.
Wow.
All right. Sawa. I want to remind the listeners that this is the interview hour of the OneMic show.
Bro.
And we're in studio with OBGYN and fertility specialist, Dr. Kireki Omanwa. Now, Dr. Omanwa is a renowned fertility expert and is also a senior lecturer at the University of Nairobi, Department of Obstetrics and Gynecology. He's with us today to talk about the taboo topic of infertility, which is not talked about so much. Now, we're going to take a quick break. You know, there's so many other things that we have to talk about. We know there's a lot of questions that are coming in. You know, like one of the things that we're going to be talking about when we come back from the break is on infertility. Is it a random occurrence? Is it genetic? Are there maybe lifestyle issues or habits that can lead to infertility? You know,
In
we're
men.
talking, alcohol, diet, weed,
Men.
Miraa. You know, there was someone who was asking about obesity, you know, exercise, you know, contact sports, you know, horse riding, biking, hot environments. All these things, we're going to talk about them.
Laptop juu ya nini,
in
juu
the
ya
social
laps.
segment.
Yeah.
All of them in the social segment, or even hot baths, you know, kukaa ndani ya bathtub. Wewe ni mwanaume mzima na unakaa ndani ya bathtub.
Kwanza maji moto.
Unafanya nini?
Yeah.
So those are the things that we're going to talk
Unajichemsha.
about in the second hour. And in the second hour we're
kusoma
gonna
gazeti kwa choo.
come on.
now you wanna wait for the next hour.
Okay.
Now and in that social hour we're gonna allow people to call. Write down this number 202-683-4570. Press star
Say it
5 to
again
speak.
slowly.
202-683-4570 and press star 5 to speak. This is gonna be in the second hour. We're gonna take a quick break and we are gonna be right back. Uno, back to you.
DJ Machachari Buddha Boska there. I won't say much.
Yes.
Twende kazi.
Yeah, just a 10-minute break and we'll be right back.
We'll be right back.
Yeah.
Kade, twende.